Thank you very much. My name is David Green. I'm an honorary consultant anaesthetist and senior lecturer at King's College Hospital and King's College London in the UK. My fellow authors for this presentation are Dr. Chris Wolfe, sadly rest in peace in July 2023, Dr. David Collier, who is in charge of the Queen Mary University of London William Harvey Cardiac Research Centre, and Professor Julian Payton, Professor of Physiology at Auckland in New Zealand, formerly in Bristol in UK. Now this lecture is about a new theory of arterial blood pressure control, which looks at the way we think of blood pressure being controlled, that's arterial blood pressure, and how it differs really from the conventional view, but also to use this new theory as a rationale for what we like to call perioperative multimodal monitoring, and I'll come back to the definition of that shortly. Now, we feel that this has clinical implications for anaesthetic practice, and it also, I think, explains why recent studies of using cardiac output monitoring, which I think is an essential component of management of patients, particularly high-risk patients, both in the emergency, but here we're really talking about the elective high-risk patients undergoing non-cardiac surgery. This explains, I think, in some way why these recent studies utilizing cardiac output monitoring have not reduced complications or mortality significantly. Now, in some of the slides we refer to papers. These are two papers which we have published. The first one is about a new radically improved model of the circulation with important clinical implications. Same authors as I've just mentioned. It is free to download and you can see the URL down below. And secondly, this is, if you like, a shortened and updated version entitled New Understanding of Circulatory Blood Flow and Arterial Blood Pressure Mechanisms, and this was published in the European Society of Cardiology. I want to pay particular tribute to Chris Wolfe. He worked with me extensively in the operating room while we were devising this new theory, looking at how anaesthesia affects cardiac output, particularly venous dilation and so on, and he was a great physiologist. He was also a pioneer in high altitude physiology. He went on a number of occasions up to base camp at Everest and recorded things like cerebral oxygenation, but very important and I think pertinent to this particular presentation, he was effectively the co-inventor with Dr. David Band, also sadly deceased, of the LIDCO-PULSCO algorithm for calculating stroke volume from the arterial pressure waveform. And I think this is one of the greatest and most significant contributions he made, because I still believe this is the most accurate method of trying to calculate volume from pressure waveforms. This led, of course, to the development of the LIDCO Rapid, following the development in the early 2000s of the basic LIDCO monitor. The LIDCO Rapid was designed for the operating room, and that PULSCO algorithm, which is used both in the LIDCO Rapid and the original LIDCO Plus, mainly used in the intensive care unit, that algorithm from 1999 has not been changed since, and this is very much unlike many of the other algorithms. And I think it remains the most validated and accurate way of determining stroke volume from a radial artery pressure waveform, and I think that's significant. There are other techniques of calculating stroke volume from, for example, the femoral artery or central arteries, but here we're talking about the radial artery pressure. Now, I make this statement, which was a statement made by William Harvey, and of course what we're talking about is nothing as significant as William Harvey, but I think it's important. The observation he made when he came up with the circulation of the blood is that it contravened a lot of people's understandings and expectation of the circulation, and he said, "I tremble lest I have mankind for my enemies, so much as want and custom become second nature. Doctrine once sown strikes deep its root, and respect for antiquity influences all men." In other words, once a certain paradigm is established, it's really very difficult to change it. He did go on to say, however, still the die is cast and my trust is in my love of truth and the candour of cultivated minds. In other words, he thought that despite some of the opposition, his message would get through. However, we also have to think about Max Planck's famous statement, a great, of course, physicist, a German physicist. A new scientific truth does not triumph by convincing its opponents and making them see the light, but rather because its opponents eventually die and a new generation grows up and is familiar with it. And I think this has a great deal of significance as well. Well, since this lecture is about blood pressure, and since this lecture also looks at the blood pressure and our new theory as it relates to anaesthesia, I think it is very important to think about why blood pressure, and particularly hypotension, low blood pressure, is so important during anaesthesia. Now, I'm not to say that hypertension is not also of some importance, but here, during anaesthesia, we are mainly concerned with low blood pressure. And I think the ball started rolling to a certain extent really way back in 2015, 10 years ago, when Terry Monk, who's professor in the VA system in the United States, looked at the association between intraoperative hypotension and hypertension. So hypotension was the thing that she basically concentrated on, and 30-day post-operative mortality in non-cardiac surgery. And basically, she was looking at a large database of patients in various VA medical centres around the States, and those of you who worked in the States will know that the major cities tend to have Veterans Affairs medical centres. I worked in the one in Dallas, for example. She looked at 30-day mortality and looked basically at how this related in terms of time-based thresholds of low blood pressure with that 30-day mortality. And please note, of particular relevance is that the BP readings were recorded only from the first detection of end-tidal CO2. In other words, usually when the patient had been intubated following induction of anaesthesia. But what she found in general, a systolic, mean or diastolic pressure of less than 70, 50 and 30 respectively for more than just 5 minutes. Now, we accept those are low pressures, but for just 5 minutes led to a 3-fold increase in 30-day mortality. So this is very significant. Now, various other authors have come on board with this concept, as we'll come on to in a moment, particularly people like Professor Dan Sessler at the Cleveland Clinic, and he looked at trying to review this combination of perioperative hypotension and poor outcome, particularly as it related to myocardial injury. There was a take-home message that hypotension is strongly associated with perioperative myocardial ischemia, acute kidney injury, and subsequently, therefore, death. The harm thresholds, of course, depend on the context, but are generally high. And they also display a couple of these hockey stick shaped in the graph here, showing that at a mean pressure on the left there, you can see there a mean arterial pressure around at 80 or 90, very low 30-day mortality, but it goes up very, very sharply, doesn't it, as the pressure drops down to up to 9 to 10-fold, and the same looking at mean arterial pressure here, a minimum mean arterial pressure, rather than a time-weighted average. So both are important. Randomized data suggests, they say, that at least some harm can be prevented by intervening to limit hypotension. So reducing hypotension may improve perioperative outcomes. So very important, obviously, step that you would take if you know that hypotension is associated with poor outcome, particularly myocardial and kidney injury, then clearly you say to yourself, let's do something about it. Let's try and see what the minimums are, and let's try and prevent these problems. Now, there have been various perioperative quality initiatives, consensus statements on intraoperative blood pressure, risk and outcomes, and this was published in a series of articles in the British Journal of Anaesthesia about 5 or 6 years ago, and they were led again by this particular one by Dan Sessler, but also we've got other very great worthy investigators like Sol Aronson, T.J. Gann, Monty Mythe, Mike Grocott, Mike Edwards, who of course was in charge basically of Optimise 2, which we'll come back to, Timothy Miller and so on. And again, they really underpin the concept that increasing evidence that even brief durations of systolic arterial pressure less than 100 millimeters of mercury and mean less than 60 and 70 are harmful during non-cardiac surgery. So again, they're underpinning those results from 4 or 5 years earlier from Terry Monk. Again, other initiatives, this is one by Gary Ackland, also very active in this area. We've also got authorships like Scott Rudney, Maurizio Ciccone, Michael Pinsky, etc. And they're basically looking at this conclusion. Now, they're saying, yes, blood pressure is important, but don't forget there is a frequently unrecognized association between arterial pressure, organ blood flow, and microvascular and cellular function, which requires further research to refine our approach to hypotension. It's not just simply dialing a drug which will bring your blood pressure up, for example, like noradrenaline, but we need to think what effect is that having on the circulation and tissue blood flow in general. So just looking at blood pressure in isolation is not necessarily going to be beneficial. Here is another paper on perioperative blood pressure management, this time by Bernd Sorgel, again a very important investigator in this area and also probably the lead author of the Pegasus trial, which I'll mention at the end, and again Dan Sessler. They look at the initial couple of paragraphs in this paper on the physiology of blood pressure and of course quote the conventional well-known equation, the physiological equivalent of Ohm's law, that pressure is equal to flow times resistance, flow being of course cardiac output, resistance is obviously systemic vascular resistance. Now I'd like you to look at this equation, not completely obliterate it, but to think of it in a different way, as we'll see as we go through this talk. But they make a couple of points during this very interesting paper. They talk first of all, as we've said, about patients assigned to individualized management were given norepinephrine, noradrenaline, continuously during surgery to achieve systolic blood pressure. In other words, if you're worried about blood pressure, then the natural thing to do is get your noradrenaline on. As soon as that blood pressure starts to dip, we then actually add the noradrenaline to keep it within 10%, which I'm sure is absolutely fine. They also go on to say a very interesting concept, and I think one which is tremendously relevant, as we'll see. The pre-incision period, in other words, the time from induction to intubation and incision is short, obviously, compared to the entire intraoperative duration. In one study, though, it accounted for 1/3 of all the hypotensive episodes. In other words, the main hypotension during anaesthesia is occurring during that induction to intubation to surgery sequence, and we must therefore not ignore that section. We talk about noradrenaline. We all use it to bring up blood pressure, but how does it work? What's it actually doing? Is what it's doing good or bad for the patient? It's certainly bringing the pressure up, we know that, and almost anyone it will bring the blood pressure up. How it works is not quite what most people think. And the other important message from this paper is that we must monitor continuously, I think, from pre-induction, particularly in the high-risk patient. Now, one of the major things we all know, going right back to Guyton, is that control of blood flow resides at the tissues. In other words, the tissues are determining how much oxygen they need and therefore trying to get adequate flow to provide for their needs. How well they do that, of course, depends on the whole cardiovascular system. In other words, running for the bus may produce incredible shortness of breath in some people because the muscles aren't getting enough oxygen, and in others they just do it without any problem whatsoever. Now, the important thing, of course, therefore, is all tissue blood flows, according to their demands, comes back to the heart by the venous system and combines to form the cardiac output. Now, clearly the heart provides the energy required to generate the pressure and, of course, the flow around the system. But flow is regulated by the individual tissues to enable oxygen and, of course, nutrients to arrive appropriately. The tissues like adequate oxygen. They don't want too much and they certainly don't want too little. This means that cardiac output, that is to say the sum of all tissue blood flows, is regulated at the tissues according to their demands. Or, as Guyton indeed said in the 50s, basically, The need of the body for oxygen is the real regulator of cardiac output. So the heart's providing the hydrostatic pressure to enable flow to be delivered to the tissues. So arterial blood pressure must be intimately related, clearly, we know this, to the volume of blood in the arterial system, in other words, the arterial blood volume. Total blood volume, of course, is not just the arterial, in fact it's a small component of it, as we'll see. It also includes the systemic venous, I've highlighted that, we'll come back to that obviously, the pulmonary vascular system and obviously capillary volumes. Now, arterial blood pressure therefore depends on the total blood volume, because arterial blood volume is obviously part of that, but also it must be something to do with the venous to arterial distribution. In other words, we could have a normal blood volume, but all that blood is in the venous system, it's not in the arterial system, so effectively there's no blood pressure. Now, arterial wall compliance, as we know, is defined as the volume change per unit of arterial blood pressure change. So the bigger volume change for blood pressure change, obviously the higher the compliance of the circuit. So compliance is equal to volume divided by pressure. We can rearrange that equation to say arterial pressure is equal to the volume in the circuit divided by the compliance. So for any change for a given compliance, any change in arterial blood pressure must therefore result from the change in arterial volume. Only possible, it's got to come from somewhere, that blood, it's got to come from the venous system. Okay. So arterial blood pressure is basically proportional to arterial blood volume. Now it's interesting and not generally considered, although I'm sure people know it, but not really at the top of their minds, as it were, that venous volume control is much more actively mediated by our sympathetic nervous system than arterial blood sympathetic control. In other words, arterial tone is much less influenced overall than venous tone. Now, when we look at the gross functional anatomy of the circulation, this is a figure from figure 2 figure in our second paper, shows quite clearly in blue that obviously the venous volume is much greater than the arterial, and it just shows how it's distributed. If we look at it volume-wise, as the relative volumes of arteries, we can see that arteries only hold about 12% of the total blood volume. 60% is in the veins and 7% is in the arterial and capillaries, and obviously in other parts of the circuit, but only 12% is in the arteries. So we don't need to lose very much blood for that to change quite considerably in terms of volume. So changes in arterial blood pressure then, and hence changes in arterial volume, must be accompanied by reciprocal changes in venous volume. So for a given compliance, an increase in blood pressure must be accompanied by a decrease in venous volume, and vice versa, and of course much more important, for example, during induction of anaesthesia, a decrease in arterial blood pressure must be accompanied by an increase in venous volume. In other words, during induction, due to changes in venous tone, as we'll see, blood flows, tends to distribute to the venous system, and therefore the pressure goes down because the volume goes down in the arteries. So arterial blood pressure depends therefore on total blood volume and its relative apportionment between the systemic, venous and arterial components. Now, what are the consequences? You have to think about this. What are the consequences of an increase in arterial blood pressure due to venous sympathetic activity and an increase in venous tone? And this, of course, can happen exogenously by giving a small dose of a drug like phenylephrine or noradrenaline, for example. When you get an increase in venous sympathetic activity, if it's central, there's an increase in venous tone, there's a movement of aliquot of blood from the venous compartment to the arterial compartment, and this has raised blood pressure. Now, if the systemic vascular arterial resistance did not change, cardiac output would naturally increase, and that would give you an unnecessary increase in flow of blood to the tissues. That is, you've just given venous constriction. We're not interested in more flow, and yet the pressure's gone up, we're going to get more flow. So what's going to happen then? How do tissues prevent that DO2 increase when arterial blood pressure increases unnecessarily, as in this situation? Well, of course, we all know that cerebral blood flow maintained by autoregulation, but it's not really top of our minds to think about this case universally, where every tissue bed is controlled by a general systemic and local version of autoregulation. And this is achieved by local tissues raising or lowering resistance to flow according to their demands. In other words, tissues say, right, I don't want that extra flow, so I'm going to constrict the input. Okay. In other words, systemic vascular resistance changes are therefore secondary to changes in arterial blood pressure. In other words, the systemic vascular resistance, the arteriolar tone isn't going up, pushing the pressure up. It's because the pressure has gone up, affecting individual tissues. Now, it's been assumed that the sympathetic nervous system innervation activity exerts control primarily in arteriolar resistance, mediating alteration in arteriolar tone and therefore increasing or decreasing systemic vascular resistance. In fact, the crucial importance of maintaining DO2 to individual tissues requires that arteriolar resistance and tone must be regulated by each individual tissue. In other words, individual vascular resistance in each individual tissue, according to their requirements, all builds up to give you the overall effect of systemic vascular resistance. So the sympathetic nervous system is actually mainly affecting the veins, and it appears that large changes in arteriolar tone due to changes in sympathetic nervous system can only occur in situations such as fight and flight, or indeed if you are giving boluses or large doses of drugs such as phenylephrine or noradrenaline. Under normal circumstances, the sympathetic nervous system simply provides a steady tonic influence on arteriolar tone, which doesn't change that much actually. So let's summarize then normal CVS control. Precise control of individual tissue DO2 means that tissue blood flows combine to give venous return. The heart normally, hopefully, will pump out what it receives, that is, its venous return, so cardiac output is regulated at the tissues, mainly subserving DO2. That's where the main mechanism is. Control of arterial blood pressure is determined by regulation, obviously, first of all, of total blood volume and venous tone, not particularly arterial tone. In other words, the arterial tone is mainly affected by changes in total blood volume and in venous system. Arterial tone is not really that important. For given circulatory compliance, arterial blood pressure depends, as we've said, on the relative distribution of arterial and venous blood volumes. What are the clinical and physiological consequences and questions that follow this new approach to how arterial blood pressure is controlled? Well, the account so far establishes a revised view of the physiology of arterial blood pressure control. Paper number 1, section 3, gives implications of this, including the possibility that a recently described cerebral baroreceptor, if you like, an ischemia detector, helps understand how normal arterial blood pressure and DO2 are linked. So what is this new cerebral baroreceptor? What is it basically doing? I think the important thing about it is that what you can get is a fall in cerebral perfusion pressure, which is separate to a fall in systemic arterial pressure, and that can occur, for example, from atheroma or abnormalities in the circle of Willis in the cerebral arteries, which are upstream from the central baroreceptor, which is controlling blood pressure throughout the body, if you like. So a separate cerebrally based mechanism must be there to protect the brain, because the brain is protected under any circumstances, even at the expense of the rest of the body. And this detector, which would otherwise cause a decrease, so if you had a defect which would cause a decreased cerebral perfusion pressure and cerebral ischemia, it can be overcome. But how does it do it? Well, certain astrocytes have been found to be sensitive to decreased cerebral perfusion pressure and will precipitate an increase in the sympathetic outflow to the venous system, obviously, predominantly, thus forming a feedback loop to increase systemic arterial blood pressure and therefore restore an adequate cerebral perfusion pressure. Now, One of the authors of this paper in Nature Communications 5 years ago was one of our co-authors, Julian Payton. Now, so there's an interesting parallel between central and peripheral chemoreceptors, if you like, and also central and peripheral baroreceptors. And this is shown diagrammatically in the next slide. And this slide takes a little bit of attention because what it's basically showing on the top left here is normal cerebral vascular resistance, and we can see here in blue is the cerebral blood flow, which is running this is going from systemic circulation to brain. We've got mean arterial pressure in purple, and we've got cerebral vascular resistance in orange. But in this particular one, the cerebral vascular resistance and the blood pressure are forming together so that the lines are superimposed. So what are we seeing in the first one? Well, this is normal cerebral vascular resistance. And you can see the superimposition here, as I've mentioned. Flow is from left to right, and at the triangular marker here, red arrow, the mean arterial pressure and perfusion pressure, purple trace, fall dramatically from 100 to 75. But, as you can see, although the pressure is going down, the cerebral vascular resistance is compensating, and that's dropping to the same amount. So if you like, cerebral blood flow is maintained at the pre-existing level. In other words, cerebral autoregulation is intact. What about the second one? Well, here we get an increase, a sudden increase in cerebral vascular resistance, and we can see that shown by the increase here in cerebral vascular resistance, the orange trace, which of course will reduce the pressure, the cerebral perfusion pressure, because we're moving from left to right, which has resulted in the fall in cerebral blood flow. However, this fall in cerebral perfusion pressure, remember, as I say, this is on the right side, this is the brain, on the left side, if you like, is the general circulation. This is going to produce a response by the astrocytes, which I've just mentioned, which will result in initial acute rise in pressure. Okay, there will be a bit of a compensation going on, but eventually what will happen is that the resistance and the cerebral blood pressure, if you like, cerebral perfusion pressure and the cerebral resistance will come back to result in return of that blood flow to the resting nominal 15 mils. Okay, that looks also fine, but this will be at the expense of an elevated systemic blood pressure to maintain that difference over that resistance. So remember, when you're looking at particularly arterial blood pressure in an elderly patient, just remember that some of that elevation might be to compensate for problems in the cerebral circulation where these astrocytes are overcoming the central baroreceptors to try and maintain cerebral perfusion. So in other words, if you drop that pressure too quickly, you will definitely affect cerebral perfusion pressure and cerebral blood flow. What about clinical measurements then and its translation into clinical anaesthetic practice? Well, this statement was made many years ago, about 25 years ago, perhaps a little bit more than that, 35 years ago in fact. I believe that a major contribution which clinical measurement has made to anaesthesia in particular, and here we are talking about not going back to the old days where we just had a finger on the pulse if you were lucky, but now we're monitoring things like cerebral oxygenation, cerebral blood flow, we're monitoring blood pressure, cardiac output, etc., etc. It's made a great contribution basically to physiology, pharmacology, physics and biochemistry into the operating room. And such measurements, I think, have enormously enriched our lives and given anaesthetists a much higher status. In other words, we're actually each anaesthetic, particularly in the high-risk patient, is actually a physiological experiment, if you like. And that statement was made in 1992 by Professor Sir Keith Sykes, who was the Professor of Anaesthesia at the Hammersmith Hospital. And I think using sophisticated monitoring, we can show these changes in venous tone, which have resulted basically in the change in blood pressure, as we'll see in the next slides. Now, I think we can say that there are good clinical evidence of systemic venous compartment change and dilation during induction and during anaesthesia. It would be lovely to measure this volume in some way, but I think the presence of monitors such as LIDCO, using the LIDCO pulse flow algorithm, which I mentioned earlier on, and of course was the co-invention of one of our co-authors, have shown that the fall in cardiac output over induction, the fall in blood pressure over induction, is due to a fall in cardiac output during induction, and not to, for example, what some people think, oh, the patient's just getting a bit of vasodilation from the anaesthetic. We can see this in the next clinical example. So what about venous volume change during induction anaesthesia? Well, this is demonstrated in the next slide. You've got some more information on the slide, but let's go to that slide by itself here now. We can see here, just to orientate you, the top red is the cardiac output. So here we can see, and it's nominal, this is not calibrated cardiac output. It's here nominally 8 litres. We can see systemic vascular resistance around about 1,000. We can see the blood pressure is 150/60 with a mean of about 90. The blue here is stroke volume, and the purple trace is heart rate. So what is actually happening here? Now, at 1, we're getting induction of anaesthesia with propofol and remifentanil, and we see, following it, a very rapid reduction, basically, in blood pressure. There is a fall in stroke volume, and there is a fall in cardiac output. Now, as you can see, the heart rate hasn't changed very much, so simply the change in stroke volume is resulting in a change in cardiac output and obviously a change in blood pressure. And we can see that well illustrated at this point here, and here, and here, and then we see at 5 surgery starts, and you can see a bit of a return to blood pressure here and to cardiac output. So blood pressure is passed. If we just look at the cardiac output, which is here running at about 6 litres a minute, it was 8 litres pre-induction. So the patient lying on the, as you were, on the operating table waiting for the surgery to begin actually has a cardiac output of 8 litres, but we see the return we think to normal is only about 5.6, 5.8. In other words, there's about a 30% or so reduction in cardiac output and obviously in oxygen delivery in this patient. And we can see that very clearly when we draw a line across it. Now, very early on, after starting using both the LIDCO, the main LIDCO, and then the LIDCO rapid during anaesthesia, we were seeing very consistently these changes in cardiac output. So what I did here is to take 18 consecutive patients aged 65 and above, most of whom were probably in the ASA3 category, and following them over induction of anaesthesia using remifentanil and propofol to a BIS target of 45. In other words, these were all anaesthetized to pretty well the equivalent amount. What I did, of course, is to correct, because these are all nominal, to corrected all the starting values to a similar value. Here, that's propofol of 10 litres. Okay, so all of them were corrected to 10 litres. And what you can see very clearly here is a massive mean reduction in cardiac output over induction in these patients. It's roughly about 40% with an average of 11 to 69%. So there's a huge reduction in cardiac output over induction of anaesthesia. And I'm very grateful to look at this here, that the fall in arterial blood pressure is basically, we presume, to a movement of blood from the arterial to the venous compartment, resulting from venodilation from anaesthesia. After all, propofol is a very active and important venodilator, specifically if you look at in vitro studies, and of course anaesthesia itself, because it suppresses the brain, will reduce the sympathetic nervous system output from the brain, which of course, as we've said, primarily affects the venous system. Now, conventional physiology would also say that this results in a fall in preload and therefore a fall in current. That's true, but we're also, I think, seeing very much the change in arterial volume relative to venous volume from the shift of blood. Now, changes in mean arterial pressure and cardiac output of induction were actually very, very elegantly studied by Mirna Petran and Professor Mert Kamenik in Maribor in Slovenia, looking at both and comparing both propofol and etomidate over induction. And they use again the LIDCO rapid. They use bispectral index to make sure both patient groups actually had an equivalent level of anaesthesia as far as we could determine. And you can see here that there was a 30% drop in mean arterial pressure of induction. So if we look at it here, we can see that although the changes in blood pressure were less with etomidate initially, but by the time you start giving the anaesthetic, sevoflurane in this example, then they're pretty well the same after 10 to 15 minutes. And when they also measured cardiac output, you can see that predominantly the major change was due to a change in cardiac output. Actually, again, substantiating the work that we had done, basically. So can this fall in mean arterial blood pressure and nominal cardiac output be avoided? Because as we've heard earlier from that paper from Sorgel and Sessler, that actually we are looking here at almost a third of all the total drops in pressure in cardiac output just over the induction sequence, which many people don't even monitor. So can we, if we can prevent that, and subsequently we'll be doing a massive job in reducing hypotension and reducing the effect of reduction in cardiac output and blood flow. Now, the traditional approach when you saw a fall in mean arterial pressure was, of course, during surgery, was to infuse large volumes of balanced salt solution. And this originated in the work of Shires et al., and the concept later described as third space loss. This was a paper that Shires wrote with Williams and Brown from Dallas. This was acute change in extracellular fluids associated. So what they tried to say was that, look, during surgery, we do need to give a lot of fluid because big changes occurring in extracellular fluids. In other words, there is redistribution of fluids during major surgeries, in addition, if you like, to over blood loss. And we can see this paper published in 1961, and they described this loss of functional extracellular fluid, which was up to 15 mils per kilogram per hour of balanced salt solutions. And this paper really, interestingly, still continues to influence intraoperative management for over, and this is now going for over 60 years. Interestingly, the study group, and they measured this by various dilutional techniques using various sulfate and so on dilutions, tagged red cells and so on, the study group consisted of only 13 patients. But it really did change practice overnight, because remember in the late 50s and certainly well into the 60s, there were certain surgeons who wouldn't even allow a drip to be put up on their patients because they said they didn't need any fluid, it was unnecessary. And they were nearly right, as it turned out, because some of this has now been not substantiated, as we know. Interestingly, though, and I think, as Michael Caine would say, not many people know this, only 6 years later, 1967, this statement was made in another paper. I think this statement should be placed on the wall prominently in every operating room around the world. The objective, and I've added perioperative care, is restoration, I would say maintenance, if you're talking about elective patients, to normal physiology and normal function of organs. Now, nobody's going to argue with that. But with a normal blood volume and normal functional body water and electrolytes. In other words, yes, you can achieve some degree of organ function, but not at the expense of overloading the patients. As they say, this can never be achieved by inundation with fluids. And interestingly, the second author of this paper was indeed Tom Shires himself. But of course, once the floodgates are open, they remain open. And in 2025, 64 years later, patients are still receiving too much fluid and sodium in the perioperative period, with implications for poor outcome. So the important point is, can this fall, as we say, in mean arterial pressure and normal cardiac output? And we've said, well, some people applied fluids, but let's think about induction, where 30% of this fall occurs. Third space loss cannot be occurring during induction of anaesthesia. That's ridiculous. So what's going on? So rather than administering fluids, our approach was to administer an infusion of a venoconstricting dose of phenylephrine. And this effect can be seen in the next slide. And here we have a similar layout to the one we saw earlier, where this is a patient who was an ASA4 patient, diabetic, renal failure, on peritoneal dialysis, high creatinine with a previous MI, and we're looking at the effect of phenylephrine at 5. Okay, so here's the induction sequence as we saw before, and we see here a big fall in blood pressure in this patient, and then we see here we start phenylephrine and we see the result of that. What I would like to focus on here though is here that as we saw before, this was our stroke volume, and you can see following induction, what you see, you can actually see the stroke volume variation which everybody talks about post-induction. And as I say, many people would have given fluid at this point. We've given phenylephrine, you get venoconstriction, and you can see the stroke volume variation goes down, the blood pressure goes up, the cardiac output goes up. No, getting pretty close actually to what the pre-induction. Forget about the numbers here. They're not, as I say, they are not calibrated numbers. Now, interestingly, the American Society of Enhanced Recovery and Perioperative Quality Initiative is rather similar to the one that we saw earlier from the BJA, came up with the statement. Now, absolute hypovolemia may or may not be responsible for observed hemodynamic abnormalities, for instance, stroke volume variation above 13%, soon after induction of anaesthesia and with institution of mechanical ventilation. This should prompt consideration of vasodilation, and we should think about vasoconstrictors. Now, I would like to rewritten that and say consideration of venoconstriction, not relative hypovolemia. Venoconstriction is causing a shift of blood, with venodilation rather causing a shift of blood to the venous system, where venoconstrictors can then reverse that change. So how do we counteract venous volume increase following induction of anaesthesia and its detrimental effect on mean arterial pressure? Well, I think we can do something about it pre-induction. We can give offset by an infusion of low-dose phenylephrine or noradrenaline a few minutes before induction. And when started before induction, they have little effect on hemodynamics. Now, this is important because many people who are dealing with high-risk patients, often hypertensive, poorly controlled sometimes, and they say, oh, I'm not going to give my patient phenylephrine because that's just going to put his pressure through the roof. No, if you give it a small infusion, which is a venoconstricting dose, all it will do is maintain the venous tone and offset some of the effect on blood pressure and cardiac output. And we can demonstrate this in the next two slides. Here's the first slide, and I will show one of the best examples, of course, which is the induction sequence of phenylephrine commenced prior to propofol. Here it is, and we can see there is virtually no fall in cardiac output from the pre-induction value right through the case, which I think is interesting. This is another case. This is the case of a whole anaesthetic, the hemodynamic chart. This is using the old LIDCO software, and what we're seeing at the end of the case is basically a summary. This is a patient in her 70s, 60 kilogram, ASA 3/4, having a compression screw following a femoral fracture. With BIS targeted, we only needed for this hour-and-a-half procedure a total of 250 milligrams of propofol to keep her BIS target round about 45. And we can see here there's been virtually no change in SVR. Little dip here in cardiac output. Basically, throughout the procedure, cardiac output was equal to the pre-induction value, as was the stroke volume. And a bit bumpy, I would admit, the blood pressure at this point, but generally speaking, the flow and the cardiac output were maintained during surgery. Now, this type of data was presented at the ASA meeting, and this is a poster in 2016. Phenylephrine commenced prior to anaesthesia, reduced the hemodynamic changes associated with induction of anaesthesia in high-risk elderly patients undergoing major vascular bypass surgery. I want to highlight the table we made here, and we've got two groups here: no phenylephrine pre-induction, 20 patients, and then phenylephrine pre-induction, and we can see number of 20, age, weight, and ASA, obviously very similar between the two groups. The fall in cardiac output we saw here, average with no phenylephrine pre-induction was 39%, with phenylephrine was 24%, so much reduced as we can see here. And if we look at stroke volume variation post IPPV, as was mentioned in that previous paper, of course, in the Perioperative Quality Initiative, you can see it was 14%, which was above, you see, above that normal 12%, and with phenylephrine, much reduced, which of course goes along with the lessened fall in cardiac output. So the important point here is that even with a stroke volume variation change of only 6% with the phenylephrine, the cardiac output can still be down quite dramatically post-induction, even with pre-induction phenylephrine. And just assuming that that value is cardiac output post-induction is equivalent to normal, because the stroke volume variation is only 6%, is wrong, as we'll see later. Now, this was actually, I think, substantiated by another trial done by my colleague Nikolai Bang-Foss in Denmark. Vasoconstriction with phenylephrine increases cardiac output in preload dependent patients. And now this is a study where basically they assess the effect of phenylephrine on cardiac index following head-up tilt induced preload dependency. In other words, you put the patient off to sleep, raise the head, clearly stroke volume variation went up, the pressure and the cardiac output went down, and they could measure the changes using lithium dilution. So in other words, it wasn't done just with stroke volume assessment of stroke volume using LIDCO, PulseCo. It was actually using proper dilution techniques. And we can see here the effective head-up tilt. So stroke volume index 43 mils per square meter, that's the cardiac index, mean pressure, heart rate. Head-up tilt, you can see the cardiac index dropped, the mean arterial pressure dropped, heart rate stayed about the same, stroke volume variation went up quite dramatically to 19, and then when you gave the phenylephrine, you can see the cardiac output came back again by about 20%, the mean arterial pressure came back, the heart rate was okay, and you can see the stroke volume variation dropped. It's very similar to the work we displayed at the ASA meeting. And this slide, slightly hidden by my face, but just shows that the cardiac index went up quite considerably with phenylephrine. So we've got a sympathetic supply to arterioles and veins. So the theoretical base we give for control of arterial pressure includes sympathetic nervous system activity causing venous tone change, but not really very much change in arteriolar tone. This is due to the greater sensitivity of the venous system to sympathetic stimulation. Now, the separation of activity of SNS outflow to veins and arterioles must mean there are differences in the central nervous system to account for these functional differences. Now, oxygen delivery bears a constant ratio to oxygen demand, and this is obviously what we've been saying all the way through as far as tissue is concerned, perhaps except for muscle, skeletal muscle. We do actually try to maintain flow according to demand throughout. Okay, obviously muscle, sometimes we exceed that demand and we build up oxygen debt in the muscle, but we can also build up oxygen debt generally, of course, if we're not careful. This can be, if you like, the constancy of oxygen extraction, basically, according to the oxygen demand. And we can see this in the next slide, basically. As you increase oxygen demand, you increase cardiac output, and of course, that is, if you like, a surrogate of oxygen delivery. And as oxygen demand goes up, then oxygen delivery goes up. And the more fitter you are, the longer you can sustain the increase in oxygen demand versus oxygen delivery. We can see in mitral stenosis, although it's okay at rest, you can see that here the cardiac output cannot increase sufficiently to maintain oxygen delivery. So in health, therefore, DO2 bears a constant ratio to VO2. Now, the physiological problem here is, how is this achieved? How are they able to do this? Well, I think here the work of Kaylin, Ratcliffe and Semenza, published in 2016, where they show the discovery of a pathway that directly signals oxygen levels in cells and its major components, I think should help. Is this an important paper? Well, I think it is, because Kaylin, Ratcliffe and Semenza shared the Nobel Prize Physiology of Medicine in 2019 for this work. So in other words, individual cells and tissues do have a mechanism, as yet I think to be finely defined, which enables them to channel appropriate amounts of oxygen into the tissues according to their demands. Now, of course, we've said, of course, that the sympathetic nervous system is mainly controlled. The venous sympathetic seems dominant, if you like, but there are also other agents like endothelin, angiotensin, which can also cause constriction. And these are, of course, frequently used in patients who are vasoplegic. When I say that, I do mean vasas. The veins and the arteries are not so reacting, as it were, to the normal mechanism. And here you have to give exogenous compounds sometimes, like endothelin and angiotensin to maintain blood pressure. So, looking at all this, we make a plea basically for specifying the effect of drugs like phenylephrine and noradrenaline and concentrating on venoconstriction rather than just that straightforward, all-encompassing term of vasoconstriction. Because it is usual to attribute the actions of drugs such as noradrenaline, which cause a rise in arterial pressure, to constriction of arterioles, as I said, as the cause. But I think we've shown that's not true. We show that experimental work supports the rise of arterial pressure, particularly when you give small doses of phenylephrine and noradrenaline in particular, to venoconstriction, which shifts some of that blood back into the arterial side, as we've seen. This invokes, in other words, this individual tissue responses which help to control the amount of oxygen and nutrients the tissues get. So overall, SVR basically is increased secondarily to individual vascular resistances. So then I think there is a need for revision of the mechanism of action and description of such medications. Since these drugs act initially by venoconstriction, I think the general term vasoconstriction or vasoactive should be avoided. Now, high doses, we fully accept, as I mentioned, of phenylephrine and noradrenaline can also constrict arterioles and reduce arterial compliance and therefore flow. And we really don't want that. We want them to raise pressure and flow by venoconstriction, but we don't want the arteriolar side because that reduces flow, because that will exacerbate the rise caused by venoconstriction. Remember, blood pressure is proportional to pressure over compliance. Sorry, it's flow over compliance. So in summary then, pharmacological actions of vasoactive drugs, veno rather than vasoconstriction, except at high doses. So at low doses, noradrenaline and phenylephrine act predominantly by venoconstriction. These drugs may cause arterial constriction as well, given at higher doses or as a bolus, leading to an increase in pressure, but decreased tissue perfusion, and this will result in a decreased venous return and thus a fall in cardiac output and DO2. Not good. This decrease in tissue perfusion and DO2 will cause tissue hypoxia. That will result in a build-up in oxygen debt and possible increased mortality. So just focusing on arterial blood pressure may give a false sense of security. So we can go right back to that initial slide from Gary Ackland and his group in the BJA saying, we need to do a bit more about this when we're talking about blood pressure. We need to think what other effects it may have, and here we have the problem that by just causing arteriolar constriction, raising the blood pressure in those circumstances is not likely to produce a beneficial improvement in outcome. So the importance of venous tone. And I think it's very chastening to find that the importance of venous tone in health and disease was already known about more than 60 years ago. In fact, about the same time as Shires published that paper on not third space, but loss of function extracellular fluids. And this is illustrated in the following paper published in 1961 in the BMJ. And Sharpie Schaefer, who's professor of medicine, and in fact, interestingly enough, Dr. David Band, who I mentioned earlier, was actually worked in the department about the same time as him when he was a very young man, obviously, when Sharpie Schaefer was there. And he looked at all these mechanisms of venous dilation. The next slide, I think, summarizes some of his more important observations. So 1961, venous tone, okay. So he was studying venous tone in patients, volunteers who were healthy, anemic, hypertensive, following Valsalva maneuver, and particularly patients receiving ganglion blocking drugs and those who were giving blood donation. Now, ganglion blocking drugs were the first drug treatment of hypertension. Prior to that, if you were hypertensive, you had to wait basically until your blood pressure was like 250 over 150 before you could get any treatment, and that was by bilateral thoracic sympathectomy. As you can imagine, a very dangerous operation in such circumstances, and took place in two parts. Did the left one time and then the right side. And then ganglion blocking drugs came in, and they were the first drugs used to treat hypertension. His statement was, "It is clear that the usual clinical practice of following such cases," this was hypotension with ganglion blocking drugs, "by the measurement of arterial pressure by the antiquated cuff method can be of limited value." Wow. I would say the same applies to induction and maintenance of anaesthesia. 64 years later, the cuff is still the main way of measuring blood pressure, and it's not good enough, particularly during induction. He also noted that venous tone is markedly increased in patients with heart failure and anemia, in other words, elderly and high-risk patients. Elderly and high-risk patients are therefore at the greatest danger from venous dilation due to anaesthesia and anaesthetic drugs. It appears that the veins and not the arteries are the major factors causing hypotension with ganglion drugs, particularly when associated with the upright position. Even then, 64 years ago, he was saying, and the same applies to anaesthetic drugs. Isn't that amazing? If people had taken notice of that paper, rather than the paper of Shires and Shires et al., we might be in a completely different position today. So pharmacological action, veno rather than arterial vasodilation, and the action of hypertensive drugs. So the importance of venous tone basically were forgotten, these drugs. Emphasis was then placed on agents which were presumed to act, I think as a student, I'm sure we all thought that these were dilating the arteries. Well, that's reduce it. But in fact, although they do that, the major effect was probably on venodilation, and the resultant tachycardia was treated with beta blockers. Although these drugs worked, but the mode of action was misconstrued. So we're really talking now about the importance of the venous system in managing hypotension during anaesthesia, and the crucial role of also measuring cardiac output and oxygen delivery. Now, a couple of papers. This was one by Chris and myself, published in 2014. Clarification of the circulatory pathophysiology of anaesthesia, the implications for high-risk patients. This preceded our understanding of that veno to arterial switch, but basically went into a lot of detail of some of the works I've taught, particularly looking at the effect of lots of fluids on the glycocalyx, and how excess balanced salt solutions actually increase third space loss rather than trying to counteract it. And another paper by Simon Gelman in the Canadian Journal of Anaesthesia and Luca Bigatello, again looking at the role of venodilation basically and goal-directed hemodynamic therapy. And remember, when we talk about goal-directed hemodynamic, we've got to think, what goals are these people trying to achieve? We get then back to the real importance of measuring cardiac output. This describes what's going on in the next slide, and it's easier for me in this presentation just to go through it. And we're talking about the importance of measuring cardiac output alongside blood pressure from the pre-induction baseline in elective high-risk patients. So here we have the slide. What we're talking about here, again, the same layout as we've seen with the VidCo. Remember, these traces are taken post hoc. You can download the software and you can visualize what happened during the anesthetic with all the observations that you've made, and running with cardiac output, SVR, blood pressure, heart rate and stroke volume, and we can see that baseline there, I've taken it rather generously, that was the baseline cardiac output pre-induction, and you can see that during anaesthesia it was reduced by nearly 70% for 10 hours. And we can see here the black line is showing the starting stroke volume, and we can see here that stroke volume has gone down about the same amount as we saw with the change in cardiac output, and we can see it here, and then we can see a black line here looking at the regional SVR. And what we're seeing here, in fact, is systemic vascular resistance going up due to arteriolar constriction, which is of course has reduced stroke volume because you've reduced cardiac output, because tissues are not getting enough blood flow. And we can see here the red line, though, looking at mean arterial pressure is absolutely fine, a mean of 75, and we can also look at heart rate. So we're just looking at a little figure on a monitor saying mean arterial pressure, and we're just looking at the heart rate and say, I want you to keep that mean arterial pressure at, say, here, 70, 75, and you produce that, so I said, I've done it. But look what's going on behind the scenes. Here, arterial blood pressure and heart rate are maintained in the normal range with venoconstricting drugs, but we've started to give higher doses, causing arterial constriction and a massive reduction, 70% in cardiac output oxygen delivery, with a profound increase in that calculated SVR-BP of the cardiac output. And you need to know when you're racking up that noradrenaline or phenylephrine because the blood pressure is a little bit low and you want to, are we getting venoconstricting and restoration of cardiac output, or are we getting arteriolar constriction and a fall in cardiac output? That's not good, but we can't tell directly from the mean arterial pressure. We can look at the pulse pressure, of course, which does give you an indication, but most people don't. I want then to finish off really with the last bit of this presentation, looking at recent trials of goal-directed therapy in major surgery. And we can see there are a number of them, and I'll update it in a moment. But you can see here, looking at the Poemus trial using the NICOM device, important points to note that in all these trials, the patients are mainly ASA 1 or 2, and these are patients who are not going to benefit from an intervention full stop. Just an ordinary anaesthetic, meticulously carried out, will probably be just as good as anything else. May not be, but it probably will be. We don't need to be doing very difficult interventions on patients who are ASA 1 or 2. And you can see even here, looking through, you can see that the mortality in the intervention group versus control is very similar. You've got the optimized first study, 60% ASA 1 or 2, 3.3% mortality. Gary Ackland's study don't mention ASA, but here you've got mortality 5%. Here he measured the pre-induction cardiac output, which is good, but didn't measure it during surgery, and then post-op tried to get back the patients to that pre-induction value. Those who came back spontaneously did very well. Those who you had to work hard to come back on didn't do so well. And two trials from Rob Snade's units, either using Deltex or Lidco, both relatively low risk patients. Again, no difference in outcome, and I'll come back to the other two trials in a moment. We now have two further randomized controlled trials in perioperative non-cardiac surgery using cardiac output monitoring, which appear to show no difference in outcomes. You might say, where do you go from here then? Well, let's look at it in more detail. This is the optimized 2 study, which looked at 2,500 patients aged 65 greater with an ASA score of 2 or greater. So they could be ASA 2, which I think is wrong. Undergoing major elective gastrointestinal surgery, recruited between January 2017 and September 2022. And they were assigned to minimally invasive cardiac output guided intravenous fluid therapy. Cardiac output does not predict intravenous fluid therapy, number one, with low-dose inotrope infusion during and after 4 hours after surgery. And remember, the optimized 1 trial used dopexamine in the intervention group in all patients, 0.5 micrograms per kilogram per minute. The main outcome measure was pretty not terribly precise, was just basically post-operative infection within 30 days of randomization. And they also looked at safety things like cardiac events within 24 hours or 30 days. And secondary outcomes are acute kidney injury within 30 days and mortality within 180 days. Very helpfully, the BMJ, where this was published as a visual abstract, and the summary says basically, and you may say, I'm not going to look any further than this, the trial did not provide evidence that the intervention could reduce the incidence of post-op infections, number one. Number two, the intervention was also associated with an increased incidence of acute cardiac events. They look at the study design and the population, as I mentioned. So minimally invasive cardiac output 1251, control 1247, infection within 30 days, which was the primary outcome, 289 in the intervention group, 283 in the control, no difference. Acute cardiac event, that's troponin increase or what have you, in less than 24 hours, 38 in the intervention group, less in the control group. Acute cardiac events in 30 days, 85 and 79, really no difference as you can see. Now, one has to wonder here, when you say what this study adds, that the perioperative chemotherapy approach does not reduce the incidence of post-operative infections, and particularly use of low-dose inotrope infusions within such algorithms should be avoided. And that's certainly true, because very few, I think one person in the control group got dobutamine, whereas I think 41 in the other group did. Sorry, many more. Routine use of this intervention is not warranted. It's quite interesting that they already knew this, really. In the optimized trial, Mike Gillies looked at perioperative myocardial injury in patients receiving cardiac output guided hemodynamic therapy, a sub-study of the optimized trial. 288 patients subset were looked at, looking at cardiac biomarkers, and they were basically hoping that they would be better, but certainly they would be no worse. And they basically showed that myocardial injury is common, neither reduced or increased, and it certainly was common. If we look at raised high sensitivity troponin, pre-induction very low obviously, but at 24 hours 30% of patients in both groups had way above the upper limit of troponin, and at 72 hours 40%, and yet something like 65% of patients were ASA 1 or 2. This is astonishing, isn't it, when you think about it? So why continue with this I think quite ridiculous use of inotropes during this surgery? Now, the iPegasus trial was again a cardiac index guided therapy to maintain optimized post-induction cardiac index. The intervention group, 152 patients, maintained optimized post-induction cardiac index during. Now, what do they mean by optimized? They assumed that the cardiac index following induction, the measured pre-induction, is the same as the pre-induction value if the stroke volume variation is less than 12%. This has never been validated and is certainly incorrect, as we saw in our study, that even with a stroke volume variation of 6% using phenylephrine, cardiac output was 24% on average lower. So that's an incorrect statement. 43% of the intervention group patients received dobutamine. Control patients, only 1% received dobutamine. The primary outcome was the incidence of a composite outcome of moderate or severe complication within 28 days of surgery. No difference in outcome. Conclusion: clinicians should not strive to maintain optimized post-induction. Well, first of all, it's not optimized during after surgery, so forget that conclusion, basically. So the reason for the recent trials being unsuccessful, that includes optimized 1, 2, and iPegasus. They chose the wrong patient groups. Too few sick patients. Wrong acceptable endpoints. We don't want to give fluids till it's coming out of the ears. We can't assume that the post-induction cardiac output is the pre-induction cardiac output. There's mistaken physiology, in other words. Unnecessary and harmful use of inotropes such as dopexamine and dobutamine, and there is no monitoring, interesting, of anesthetic depth or oxygenation in these patients. So as far as I'm concerned, these trials prove absolutely nothing. And of course, we also have to remember the necessity to send all patients to HDU and ICU for at least 4 to 6 hours. So wrong patient groups, average age 70, ASA 1 or 2, 45 to 60%. Wrong endpoints. Look at this. All patients receive standard measures to maintain oxygenation. That's oxygen saturation of greater than 94%, hemoglobin greater than 80 grams per litre, core temperature, yes, heart rate less than 100. Optimise post-induction cardiac index of greater. They're still using this nonsense of 2.5 litres per square metre, which is absolute nonsense, and using dobutamine to try and obtain that target. Nonsense. If we take the normal pre-induction value of 5 litres per minute cardiac output, 140 grams per litre hemoglobin, saturation 97%, if we multiply that out, multiply by Huffman's constant 1.34, we get 900 mils of oxygen delivery per minute. If we have, during surgery, a so-called acceptable low hemoglobin of 80 and a saturation of 94%, that results in 400 mils. That's a more than 50% reduction in oxygen delivery. That's not the same as pre-induction. That patient is not getting adequate oxygen delivery. But maintaining the values at 85% of pre-induction value, that results in 765 mils, which is double what they were achieving in some cases. So think about that. Answer then, we must use a multimodal monitoring strategy with individualised patient care and avoids the use of inotropes and post-operative HDU or ICU. What do we mean by that? What is that goal? It's about avoiding the build-up of oxygen debt. How can we do that? Well, we need pre-induction systolic blood pressure or systemic blood pressure, cardiac output and oxygen delivery measured with a monitor such as LIDCO or the Root, Masimo Root with pulse oximetry, with cardiac output, the LIDCO PulseCo algorithm built in, with, of course, hemoglobin as well. We can really do that now. We've got it all together now. Fantastic. We maintain that. To be able to maintain that, we often, we always need adequate depth of anaesthesia. If we've got a very deeply anaesthetised patient, we're struggling to try and maintain that pre-induction value. We can also use SEDline if we want as well. We need to maintain cerebral and tissue oxygenation, and also we basically can do that very simply with something like the Infos cerebral oximeter or the O3 from Masimo, and all that allows us to individualise hemodynamic management based on the almost total reduction of oxygen debt. Does that work? Does it reduce perioperative mortality and complications? Well, our study, which is multimodal oxygen monitoring in observational case areas in high-risk patients undergoing major peripheral vascular surgery. And I think in such studies you have to say, why do we want to do this study? What's the problem? Well, the problem with us is these patients were so sick that they all needed to go basically to HDU after surgery, and they just weren't the beds for them to go. And yet, quite often, they seem to do quite well. So, thought, well, we're cancelling one after another. So we decided, look, we're going to use this technique, multimodal monitoring, and we're going to see how we get on in these patients. So I'll go back to PACU, obviously, and if we find that 5 out of 6 actually had to go to HDU, then we'll know we're not doing the right thing. So we looked at 120 consecutive very high-risk vascular patients. Now, all these patients were ASA 3 or more. So they weren't ASA 1 or 2, they're ASA 3. 80% were femdistal bypasses, often considered by my colleagues as the first stage of a major amputation, a waste of time. Why do you bother? Duration, long duration, a lot of opportunity for build-up of oxygen debt. We were able to maintain the mean cardiac output and cerebral oxygenation at 87% or above pre-induction values with a BIS target of 44. The overall fluid requirement was only 5 mils per kilogram per hour, so not a massive amount. Our major amputation rate was 2% at 1 year. Only 2% of the patients who survived 1 year, and 105 did survive that first year. They were obviously very sick, some died from other causes. 0% in diabetics. Only 8% needed HDU ICU. In the optimised trial, in the intervention groups, most all patients went to HDU ICU. So we were able to bypass HDU ICU. They spent a few hours in PACU, went back to the ward. No inotropes were used, interestingly, only phenylephrine and ephedrine. What was the outcome? 30-day mortality was 0.8%, and the predicted in similar studies would have been 5 to 10% in this patient group. It's not a randomized controlled trial, it's a sequential trial. We also have a similar, in a way, situation in Zagreb, where the orthopedic and trauma surgeons had real problems. They had a lot of elderly patients who, and not having a proper PACU, they would have to have a bed booked in HDU ICU after the operation, and they weren't available. So what tended to happen, these patients who were very sick, as you can see, they were 5 days before surgery, they spent 10 days after surgery, 31, nearly 70% ended up going to ICU, so they needed the ICU, and the total hospitalization date was 15 days. So Yana Kokler, who's an anaesthetist, decided to then do a follow-up study, here again looking at our multimodal monitoring protocol. Exactly as I've mentioned, she used noradrenaline rather than phenylephrine, but it's very similar to what we were doing, basically similar patient group you can see. She reduced the time before surgery, the days after surgery, the ICU admissions 3 rather than 43, and hospitalization days dramatically reduced. And interestingly, the mortality in her group was 0 in the multimodal monitoring group and 20% prior to that. So there was a definite need to treat these patients. There was high mortality. They spent a long time in hospital. They weren't getting good treatment. We introduced multimodal monitoring, and it had a dramatic effect both on mortality and length of stay. And this data was presented at the ASA meeting in Chicago in October 2016. So we look at the mortality rates again. We can see here going through these, as I mentioned before, and here therefore we've got ASA status. Look, 1% in our trial, 1% in Yana's trial, mortality 0.8 and 0%. So what do we believe the advantages of multimodal monitoring? Well, it provides, first of all, greater insight into what's going on. If you start at pre-induction, you can really see what's happening to the patient. It allows individualized management centered on the minimizing the build-up of oxygen debt. Optimizing anesthesia should and does improve outcome, especially in elderly high-risk patients. So the clinical implications and recommendations for anesthesia management, basically, in high-risk patients, monitoring the major parameters, including cardiac output, oxygen delivery, and tissue oxygenation, should occur before induction of anesthesia. And these parameters should be maintained as close as possible to the baseline measurements throughout anesthesia and surgery. Inotropes, such as dobutamine and dopexamine, should not be used. These inotropes show no benefit and possible harm. Arterial blood pressure, mean arterial pressure, should not be maintained at the expense of reduction in cardiac output and DO2, and we've seen that in previous slides. Since cardiovascular depression is proportional to cortical suppression, monitoring the depth of anesthesia is recommended clearly. And in addition, we should be able to measure tissue and indeed cerebral oxygenation. And I think we should maintain it at 90% rather than 75% as in some cases. So thank you very much for listening.